Thank you very much for the opportunity to come and talk to this very impressive meeting. I have to say the organisation has been very, very good. So, unfortunately, I had to have a slight last-minute change in plan because my computer that I was working on my plan talk about the history of coronary stents crashed this morning, and I just couldn't resuscitate it. So, this is a talk that I gave at a conference last week. So, I think it's still very relevant and hopefully will be of interest. So, what I'm talking about is very specific to cardiology, ACS, acute coronary syndromes, and all of you are kind of med students with, you kind of understand, hopefully you've got enough. Well, just to give me a rough idea, what kind of year are most of you in? Just shout out. Third year, fourth year? Fourth year, okay, so you've hopefully started on a bit of clinical stuff, and a lot of the principles that I'm going to talk about are going to be familiar to you. But I think, when I talk about management of ACS, what I'm really talking about in brackets at the beginning is risk management. And in cardiology especially, we're hugely lucky that we've had very, very innovative clinicians, researchers, and we've really been at the kind of the cutting edge of clinical medicine for many, many years now. We're blessed with a huge amount of commercial, of research, academic, massive trials. You know, when we talk about cardiology trials, we're talking about 20,000 randomized patients, which is really kind of almost unsurpassed compared to other streams of medicine and surgery. So we've got a very, very firm evidence base. There's been a huge amount of investment in the specialty, and we've made just enormous strides over the last 20 or 30 years. But like a lot of these other medical and surgical specialties, how you actually apply all of this innovative technology still remains very, very important. You might have kind of billion-dollar technology available to you, you might have all these wonderful drugs, but if you give kind of the wrong patient the wrong treatment at the wrong time, you're not giving any favours at all. And that's why the fundamental principles that you guys learn in medical school of sitting next to the patient, and this really goes back to the kind of the very ancient days in Greece with Hippocrates and Asclepius, you know, sitting with the patient, taking a history, looking at that particular constellation of symptoms in that particular patient. And that is absolutely fundamental to everything that we do. So it's easy to get carried away with all the high-tech stuff, but at the end of the day, you need to deliver a specific patient, a specific treatment to a specific patient at a specific time. If you get that wrong, it doesn't matter how much money you spend on your equipment, you're never going to get the patient better, and you may even do them harm. I apologise if I cough, I've got a bit of a cold as well. So when we start off talking about acute coronary syndromes, I think it's very important to emphasise that this is a spectrum of disease. Okay, now previously we divided up coronary syndromes into kind of ST elevation infarcts and non-STEMIs and unstable angines and stuff like that. And that's useful to an extent, but it also complicates things. And that was largely due to the limitations of the treatments we had available. You know, if you go back to the 1970s, basically you had a heart attack, you know, you got given an aspirin if you were lucky, you were given morphine to get through the pain, and then you were put on 6 weeks bed rest, and if you lived, you lived, and if you died, you died. And that was basically it. And that was, you know, there are still consultants working in the NHS who trained to manage myocardial infarction like that. And it's just changed unimaginably since then. But a lot of the old kind of distinctions between different types of disease persist, and unfortunately still hamper a lot of the way that we try and approach the management now. So it's very important that whenever we talk about ACS, we talk about a continuum of disease, okay? And that's why the actual stratification of whereabouts your patient is on this particular chart is so important, because it makes a big difference in terms of how we manage it and the acuity of how we manage it. You know, does this mean treatment within minutes, hours, days, weeks, or even months? And if we don't get that right, then we're going to start making some mistakes and also overburden our healthcare system as well. So when we go back to the very, very fundamentals of what happens in an acute coronary syndrome, it all comes down to what's going on in your kind of lipid-rich core, in your atherosclerotic plaque inside your coronary artery. And we know that there's a difference between one end of the spectrum where you have these kind of angina, stable symptoms, through to full-blown ST elevation myocardial infarction at the other end. And then fundamentally, it's, you know, if you look at the coronary angiogram or if you look at a kind of a luminal stenosis, you know, these two look fairly similar, but they're actually very, very different animals. You know, one has got this kind of thick fibrous cap that's walling off the vascular blood supply from all of this kind of necrotic core full of lipids and calcium and crystals and macrophages and inflammatory material. And this is relatively stable, because you can see there's a big difference between the activate platelets and the other coagulation factors in the blood, and this horrible nasty stuff that's walled off in this atherosclerotic core. Whereas in the lesions that tend to kind of erupt and cause your problems, you've got a very different histological appearance. You've got this very thin fibrous cap, you've got a huge necrotic core, and you've got these very kind of areas of vulnerability. Now, we don't know exactly what it is that is the crucial event that actually causes plaque rupture, but it's thought to be a combination of environmental, inflammatory, physiological, genetic components which come together and cause this kind of catastrophic event where you have this big, rich plaque core, you've got the thin plaque, and then suddenly at some point there's a rupture. And then when this inflammatory kind of prothrombotic material gets in contact with the blood, it provokes the most vigorous kind of almost volcanic reaction inside the blood vessel that causes rapid propagation of thrombus, platelets, fibrin and everything else. And how we manage that is crucial. Now, there are lots of different ways that when we talk about treatment of acute coronary syndromes, there are both medical things which involve very powerful antiplatelet drugs. There are antithrombotic drugs, anticoagulants and fibrinolytics. And then, of course, once the patient's had the event, you then ideally want to stop them coming back in a year, 2, 3, 5 years' time with a second event. So risk factor modification and secondary prevention is terribly important as well. And that's where your drugs like statins, beta blockers, ACE inhibitors come into it. But in the heat of the moment, when you've got that patient with a blocked coronary artery, it's all about getting blood to that area of heart muscle. And there are ways of doing that is through revascularization. And yes, kind of 10, 15, 20 years ago, and probably in many parts of the world now, we still use fibrinolysis or thrombolysis, but that's really gone out the window in the UK and most kind of first world countries where there's a universal program now of 24/7 primary angioplasty. And the reason for that is that, I'll come on to that in a moment, but how you actually choose these different treatments is absolutely crucial, and as I said, depends on the presentation. And the way that we work out kind of who should be treated, when and how, depends on a process of risk stratification. And that then really is to try and work out where your patient is on that big kind of continuum of the ACS, from the unstable, from the stable kind of coronary syndromes at one end all the way through to full-blown ST elevation. Because if something like 30 or 40% of people coming to an emergency department have got chest pain. Now, we're not going to rush all of those people to the cath lab at 3 o'clock in the morning because we would just be completely overwhelmed. And plus, a substantial portion of those don't need that, and they may actually be harmed by that. Having said that, there may be some people that, at the other end of the spectrum can be settled and actually treated much later. And it's about us making these very difficult decisions on our ward rounds and our CCUs to actually allow access to the care for the right person. There are lots of things that we use. We use biochemical markers, we use imaging, we use angiography, Grace scores, etc., etc. And we're going to talk about how we actually formulate this to make an individual treatment plan for a particular patient who we kind of come across. So at the most extreme end of the spectrum is where you've got the full-blown blockage caused by that propagating thrombus, that kind of volcanic thrombotic response, this kind of activation of the coagulation cascade that I'm sure you can all draw out without any problem at all, and where you actually completely block off the artery. And this is the right coronary artery, and you can see that when we take our angiogram, we can see it's completely occluded in the mid-vessel here. The picture on the left is after they've had a successful angioplasty, and you can see that there's nice restoration of blood flow. And the reason it's so important is that if we don't open up that artery quickly, we end up with this, and this is a post-mortem example where you can see there's transmural myocardial infarction. Okay, so we talk about ST elevation that's caused by the kind of transmural infarction caused by blockage of a major epicardial artery. And you've heard this adage, sorry it's a bit small, the screen's quite small, but time is muscle is the kind of the adage in A&E departments, and as soon as these patients hit the ground, it's absolutely vital that they get rushed to the cath lab, or if you're not in a PPCI area, that they get their thrombolysis as soon as possible. Because you can't read the writing here, but I'll read it out to you, that this is a very important study that was published in the New England Journal of Medicine, and it showed that every 30-minute delay to delivering treatment resulted in a 7.5% relative risk increase of mortality. So we're not talking about any other. Mortality is the hardest endpoint there is. So if you delay treatment by an hour, it's 14%, hour and a half, 21%, so on and so forth. So if you've actually got some sort of systemic delay where you don't identify the patient quickly enough, you faff around waiting for porters, you don't look at the ECG, you don't follow it up, 2-3 hour delay, you're looking at a 30, 40, 50% increase in mortality in your patients. And this really changed almost overnight the way that we manage these patients. You can also see that the degree of salvageable myocardium, and when we talk about salvageable myocardium, we talk about territory at risk. So if you imagine all the heart muscle that's supplied by this artery, if you leave that blocked, all of that muscle is going to die, okay? Now, if you open that up, then the salvage is the proportion of muscle that is rescued, as evidenced by follow-up imaging that shows that the heart muscle is alive, versus the potential area at risk. And the salvage is what you get. So if you can get as much salvage as possible, that is what is considered a good result, because the more myocardial scar and unsalvaged myocardium you get, you're left with impaired ventricular function, and then that known spiral of heart failure, mortality, and death. So, early revascularization in STEMI is absolutely vital. And I can show you here just one quick example. 40-year-old male. This is one of my first cases, actually, after I became a consultant a few years ago. He actually presented to Barnet A&E. Now, Barnet is a local district general hospital to the Royal Free. It's about 10 miles up the road. They don't have on-site EAPCI, but they're part of our network. So as soon as they hit the deck in A&E at Barnet, they get transferred immediately to the Royal Free for primary PCI, where our team were ready and waiting. I don't know what your ECG interpretation skills are, but hopefully most of you will recognise that that shows significant intralateral ST elevation. And when we took the patient to the cath lab, sure enough, you can see here an angiogram showing an occluded circumflex vessel. And then after we've restored the flow of blood, you can see that there's a critical atherosclerotic stenosis here, which was the source of the plaque rupture and the occluded vessel. And we fix that with a stent, and we get a nice result. And this guy went home 2 days later, okay, and he had a follow-up echocardiogram that showed completely normal left ventricular function, and I saw him in clinic not that long ago, and he's living absolutely well. Compare that to how he would have presented back in the 70s. He would have been put to bed, he would have ridden out his infarct, and at age 40 he would have been condemned with probably an ejection fraction of 15-20% and a mortality worse than bowel cancer. Okay, so the treatment has moved on that far. And when you look at the audit data for the way that we manage coronary syndromes, almost the activity, and this is activity that we do in the UK as part of the NHS. One of the wonderful things about the NHS is it's the fact that we all work as one unified organisation, which means we all share our data. You look in the USA where every hospital's kind of competing against each other, it's all private. You just don't get this cooperation with people giving their audit data. So one of the huge strengths of the NHS is that we share, and as part of the British Cardiac Intervention Society, we have to submit all our data every year for analysis, and so there's a huge amount of information that's available. And you can see here that in the mid-2000s, the amount of work we did in the cath lab dealing with acute coronary syndromes, i.e. the yellow bar crossed over. So actually the majority of the work we do now are for these acute syndromes rather than just stable angina. And most of that is driven by this exponential increase in the amount of primary PCI relief and ST elevation and infarction. You can see here that the amount of thrombolysis we do briefly kind of went up in sync, but it's now trailed away, and it's almost never ever done. We don't even stop from fibrinolytic drugs in our CCU anymore. Now, when we're looking at primary PCI, it's very important to be very, very quick, and you have to have efficient systems. And again, as part of our kind of audit, we audit something called our call to balloon time. So that's when the patient first raises the alarm, all the way through to us actually inflating the balloon in the artery. And if these aren't within nationally directed times, then these hospitals get investigated and possibly even closed down. And at the Royal Free, we're very, very good. We're well within the error bars there. You can see that our door to balloon times and call to balloon times over high, almost 100% of them we get within our target. So it's a very efficient team. A lot of people involved. 2 o'clock in the morning, getting lots of people in the cath lab ready. It's a big undertaking, but we feel it delivers a very, very good service to our patients. So case 2 is a slightly different example, and this is where I was saying earlier that we're still slightly fixated on the difference between ST elevation and non-ST elevation infarction. For ST elevation, back in the day of thrombolysis, they were the ones who got all the Rolls Royce treatment because they're the only ones who had any benefit from thrombolysis. If you had non-ST elevation, the benefits of thrombolysis were less good, and that's mostly because the potential side effects of thrombolysis were so bad. You know, you had your intracranial bleed or you had your other bleed, so the risk-benefit wasn't in favour. So if you were a similar 43-year-old who presented with this ECG, despite having an almost identical presentation, not that long ago, you'd have been shunted off to a general medical ward. Okay, you may or may not have been seen by a cardiologist 3-4 days later. You probably would have gone home with or without an exercise test. You may have got 6-week cardiology follow-up appointment. You then may have had an angiogram at 6 months later, and then you may have had a PCI maybe 6 months after that. So it was the difference between ST elevation and non-ST elevation was very, very stark, and these people we know do terribly badly. We've changed all of that now because we recognise this continuum, and actually it's nonsense that, you know, if you've got a 43-year-old man presented with severe chest pain and a very, very abnormal ECG, just because, you know, he happens not to have ST elevation at that particular moment, he gets a completely different treatment. So we now treat these all the same. They have direct access. We're the only cardiac unit in London that has no ring through for the ambulance. They just bring these patients straight to us, and we take them straight to the cath lab. You can see here that this guy's got a subtotally occluded LAD. It's not completely occluded. What happens with these things is that they kind of block off and unblock, block off and unblock. And if you happen to have done your ECG when it had completely blocked off, he would have had ST elevation. But then often you know, for whatever reason, a little bit of blood gets through and the ST segments come down. And if you have that guy on continuous 12-day ECG monitoring, you can guarantee his STs would be up and down. So it's a real lottery if you happen to have just measured an ECG at the wrong time. So we've changed all of that now, a total change in our management strategy. And again, we think it's a lot of work, but it's definitely the right thing for our patients. You can see here the stuttering flow. Again, we treated with thrombus aspiration, stent, and a lovely result. Okay, so just to sort of show that this continuum at the top end means that we're kind of extending the population. It's bad for us that we're up in the middle of the night more often than now. You know, it would be unthinkable that our forebears, even 10 years ago, would have got out of the bed for a non-ST elevation infarction, but this has now become sort of standard practice. And this was reflected in the London Cardiovascular Project, in which the Royal Free was a major contributor, and we acknowledge that actually these very, very, what we call end-stage acts, unfortunately the nomenclature is very confusing, but these high-risk acute coronary syndromes without ST elevation deserve very, very rapid treatment. And this is also reflected in the current guidelines from the ESC, that they recommend treatment within 2 hours, which is effectively immediate treatment if you've got ongoing symptoms and high risk. But how about for those patients that have non-ST elevation and they've actually settled and they don't have pain and they're sitting there quite comfortably? They're actually saying they want to go home because they feel fine. They've been given a slug of morphine, you know, they've had their aspirin and they actually feel fine. So we need to have some other way of actually managing their risk. And one of these things, I was interested to see your previous talk. I'm sure this kind of thing developed from one of your kind of technical things. There's a little app for this stuff now. Which was very popular. And the GRACE basically was a huge study with 20-odd thousand patients where they literally looked at a whole bunch of patients with presented myocardial infarction. And they looked at those that were alive at 6 months and they looked at those that died at 6 months. Very, very, you know, simple question. Huge undertaking with this number of patients at, you know, hundreds and hundreds of hospitals throughout the UK. They followed up with national Office for Statistics and mortality figures, so again, hardest kind of endpoints that there are. Unfortunately, there's quite small again, but if you see these, so basically the ones in red are those with ST elevation, so the highest risk groups. The one in the dotted lines are non-ST elevation, and the green lines are kind of unstable angina, straightforward ones. And unsurprisingly, when you look at in-hospital death at 10 days, highest risk group are those that have completely blocked off their arteries, because these are the people that just drop dead. Often none of them even make it to the cath lab. And if you look at that followed out to 6 months, you can see that still the ST elevation are the highest mortality, but most of that risk is accumulated in the first couple of days, and then after that, it actually plateaus out. But what was really interesting about this study was that if you actually take, not from a hospital admission, but from hospital discharge, so if you actually survive the first few days of your infarction, actually the non-ST segment elevation group are the ones that accrue most events. So this makes sense because these are the ones that don't get the right treatment. These are the ones that are sent home without a stent. These are the ones that end up on the general medical ward seen by an elderly care physician. With all due respect to elderly care physicians, they're not the people that should be looking after young 40-year-olds with ST elevation. So this, with the GRACE, they basically looked at all of the factors that contributed to you dying sooner. Okay? And then they put those, they boiled everything, they looked at hundreds and hundreds of different parameters, and they boiled it all down to these key factors. And then they made a kind of a scoring system so that when a patient comes in, you can actually tap this into your phone app, and it will give you a what we call a GRACE score, and that puts you into tertile with a low, intermediate, or high risk, depending on what the score is, and that predicts your hospital mortality. And this was actually then shown in a big study called the TIMAC study, where they looked at immediate treatment for people with going to the cath lab versus delaying it for a few days. And although the primary endpoint didn't show anything, when you actually divided the patients up according to their GRACE score, there was a significant risk reduction in those who were the GRACE score predicted to be high risk versus those that were low to intermediate risk. So for the first time, when this kind of fairly heterogeneous group of patients coming in, we can apply a kind of validated risk score to them, and then we can use that to actually plan their treatment rather than using day of the week or sticking a finger in the air or tossing a coin trying to make these decisions. It's all about trying to be a little bit more objective and a little bit more reproducible in the care that we give our patients. And there are plenty of studies that have gone on to actually validate this further. I'm just going to zip through a little bit, and again it's validated, it's mentioned in the latest update from the European Society of Cardiology. There are some issues with GRACE, however, because it predicts death. It's massively influenced by age. So if you've got an old patient, they're going to die, and this is a big problem. And so, on an individual patient basis, you need to be very, very careful. So this is another example, 37-year-old. In fact, this was a Malaysian student, by no coincidence whatsoever. And he was a bodybuilder. He liked going to the gym, and he was lifting some weights at 2 o'clock in the afternoon. He was a smoker, but no other real risk factors. Felt quite unwell, and came to A&E, and at the time his symptoms actually settled. And this was ECG, and I won't spend too much time on it, but needless to say it's fairly normal, and I don't think anyone, any young man without risk factors who's been lifting weights in the gym, who's now settled, probably going to say this guy's fine really, he's probably just pulled a muscle because he was trying to bench press too much. However, we did a blood test called a troponin on this man, and it came back positive. So the guys in the middle of the night were worrying about this, but actually he started then getting more chest pain, so the kind of decision got made, and we decided to take him to the cath lab. And you can see here that his left coronary artery is absolutely fine. If you look at his right coronary artery, he's got a critical coronary disease here, which we then treated again. So you've basically seen 3 sort of patients with very different presentations, very different kind of risk profiles, but having very similar kind of coronary disease, and this is what we're finding as we're looking at more and more closely at this group. So hopefully all of you have heard of high-sensitive troponin. It's become a real sort of part of acute medicine, and it's a vital tool really we use in terms of making the diagnosis of ACS. The prognostic implications are very, very good. And multiple trials have shown that a raised troponin is associated with high chance of myocardial infarction and therefore poor prognosis. The assays that we use are more and more sensitive, and the problem with tests, as you know, as they get more and more sensitive, is they get less and less specific, and the pickup rate of false positive troponins is a major problem actually in A&E departments. And this was the president of the American College of Cardiology. So when troponin was a lousy assay, it was a great test. Basically, it was poorly sensitive, very, very highly specific. So if you went in and you had a positive troponin, you're probably going to miss a whole bunch of them. If it's positive, you are almost 100% guaranteed this patient's having an infarction. Now it's become a fantastic assay. You can pick up tiny, tiny amounts of troponin in the bloodstream. It's getting to be a lousy test because it's relatively poorly sensitive. So I'll quickly rush through this because I appreciate time. So it's about, when you're using it as a test, it's vital that you look at the release kinetics of it. And this is something that when you get into the clinical shop floor, you'll become very aware of, because there are very distinct patterns of troponin release. In infarction, you get very acute rise, so it's important to look for that dynamic incremental increase. Heart failure and other conditions, you have a much more indolent release. And plus, it's not just raised in cardiac cause, acute infarction. There's a whole host of other things, everything from sepsis to renal failure, pulmonary embolism, tachyarrhythmia, myositis, anything like this can also cause unraised troponin. So it's a very useful tool, but again, you can't rush every patient with a high troponin to the cath lab because there's you need to use your clinical brain. All the stuff you're using at the moment about analysis and looking at the patient in front of you is very important. But the ESC and everything else have published all sorts of guidelines about how we should measure it, and they should look for an incremental change in terms of your clinical risk stratification. And at the other end of the pathway, we get all these 40% of patients coming to A&E. We can't admit all of them to hospital, so we need to find ways that we can rapidly discharge them. And there are lots of trials showing that actually if you look at your patient, you look at their risk factors and they have a negative troponin, they've got a very, very, almost 100% negative predictive value, so we can safely send these patients home without the unnecessary admissions that we used to do not that long ago. And we put all this together, and I was kind of the lead on this at Rule 3. We've sort of all of that information, all those trials, all those guidelines we put together into one big pathway here. So your patient presenting with chest pain, your acute medics, your A&E, ITU, anyone can work through this, and hopefully we can have a slightly more consistent approach to the management of these patients. And it's important because this is some of the research work we're doing, looking at the inside of coronary arteries with something called ACT, and 3D reconstructions and all the sense. So there's a huge amount of innovation and technology out there, but it's vital that we actually use it in the right patients at the right time. So in summary, there's no doubt that for patients presenting with ST segment elevation myocardial infarction, they require immediate PCI. These people do not require blood tests. These people do not require CT scans. These people do not require anything else. These are all the things that when we look at the root cause analysis for delays, these delay things. Think of that 7.5% mortality for every 30 minutes. If you spend half an hour, taking bloods, putting in an art line, getting central access, this, that, and the other, you're basically increasing the chance of your patient dying, and there's nothing that you're going to be doing is going to make any difference. If they don't have ST elevation, then we need to sometimes use our brain to look at other ways that we can risk stratify them rather than just sort of depending on whether it's a Monday, Wednesday, or a Friday and which consultant's on or which ward they happen to end up on. So we're using these objective scoring systems called Grace, troponin. All of them are useful, but all of them have their limitations. So it's about using all of these tests together, but at the end of the day, your clinical judgment trumps everything else. We know that based on Timax and other risk stratifications, if you've got high-risk features, and you've got non-ST segment elevation, you should have early coronary angiography and stenting. And it's absolutely vital. I haven't talked about it today, but you have your concomitant drug therapy. There's no point in putting a stent, a metallic stent, into this kind of very, very aggressive inflammatory environment of a blocked coronary artery if you then don't also give medication to block the platelets and stop it happening again. And always consider the individual patient in all of these treatment decisions. Thank you very much.